Thank you very much. Welcome. Thank you very much. Welcome. I'm Dan Feltus, the Chair of the Commission on the Status of Health Coverage Markets for Individuals and Small Employers. We're having a virtual meeting. Just like all of these commission meetings, we have to read a disclosure. And I will read that. We'll go over the agenda and we'll jump right in. So today we're conducting a remote meeting of the Commission on the Status of Health Coverage Markets for Individuals and Small Employers. Before we get started, I'll read through a checklist to ensure that the meeting that we are holding is in compliance with the right to know law. I find due to the state of emergency declared by Governor Sununu as a result of COVID-19 pandemic, and in accordance with Governor Sununu's Emergency Order Number 12, pursuant to Executive Order 2020-04 and its extensions, this public body is authorized to meet electronically. Please note that there's no physical location to observe and listen contemporaneously to this meeting, which was authorized pursuant to Governor Sununu's emergency order. In accordance with the emergency order, I'm confirming that number phone with additional access possible by video and other electronic means.
You're still breaking up a little bit, Senator, just to let you know.
We're utilizing Zoom for this electronic. Let me go off video. We are public access to this meeting by phone. Is that better, Alan?
It's not really, no.
Okay. Hey, Alan, I'm going to jump on a different computer and then I will be right back in, okay?
Yep, you got it. Thank you guys for your patience.
Commissioner, you want to sing or something to help get us through this silence?
I can assure you, you don't want to hear me sing. Even under the best of circumstances, it's not good. But it is Friday afternoon. We got through our rate hearing this morning, so it's a pretty cheery day from my perspective.
So I found this morning very, very interesting. This is Representative Hunt. That was great stuff. I really enjoyed that presentation.
Yeah, I love the data. I just, it was broken down in pieces that I could.
All right.
Kind of.
Does this work?
Very good, Senator.
That sounds great.
Okay. I apologize for that. I'm on a different computer. This is the world of Zoom, right? Well, thank you for everybody for your patience and bearing with me here. I should probably start from the top and read this disclosure once again. I'm going to read the disclosure that we have to read for these virtual meetings. We'll go over the agenda and then we'll jump right in. Welcome I'm Dan Feltus, the chair of the Commission on the Status of Health Coverage Markets for Individuals and Small Employers. Today we'll be conducting a remote meeting of the Commission of the Status of Health Coverage Markets for Individuals and Small Employers. Before we get started, I'll read through a checklist to ensure that the meeting we are holding is in compliance with the right to know law. I find due to the state of emergency declared by Governor Sununu as a result of the COVID-19 pandemic, and in accordance with Governor Sununu's Emergency Order Number 12, pursuant to Executive Order 2020-04 and its extensions, that this public body is authorized to meet electronically. Please note there is no physical location to observe and listen contemporaneously to this meeting, which was authorized pursuant to Governor Sununu's Emergency Order. In accordance with the emergency order, I'm confirming that, number one, we're providing public access to the meeting by telephone with additional access possible by video and other electronic means. We are utilizing Zoom for this electronic meeting. All members of the commission and selected legislative staff have the ability to communicate contemporaneously in this meeting through this platform. And the public has access to contemporaneously watch and or listen to this meeting on Zoom, YouTube, and via phone by following the directions and links provided on the General Court website. Number two, we have provided public notice of the necessary information for accessing this meeting in the Senate calendar, assuming you have a functional computer, which I just found. Number three, we are providing a mechanism for the public to alert the public body during the meeting if there are problems with access. If anyone has a problem, please email remotesenate@leg.state.nh.us. Again, remotesenate@leg.state.nh.us, or call 603-271-3043. Again, 603-271-3043. Number four, in the event the public is unable to access the meeting, it will be adjourned and rescheduled. Number five, please note that all votes taken during this meeting, if any, shall be done by roll call vote. And finally, let's start the meeting by taking a roll call of attendance. When each member states their presence, please also state where they are located. And if anyone else is in the room with you during this meeting, which is required under the right to know law. I'll begin. Dan Feltus, State Senate Majority Leader, Senate District 15, Office Building in Concord, by myself. And I'm going to turn it over to Deputy Chief of Staff Alan Raff, who will call the roll.
Thank you, Senator. Senator Kevin Kavanaugh, do not see him. I have spoken to Representative Williams. He will be absent today because he had a prior engagement. Senator Harold French. Do not see Senator French. Representative Ed Butler. No, all right. Tyler Brannon.
Sure. I'll just take a
Tyler Brennan, I'm at the insurance department. I'm in the room with the commissioner. Otherwise, I'm alone.
Thank you, Tyler. Representative John Hunt.
yes, I am here. And I am by myself and actually in Westerly, Rhode Island.
Thank you, Representative. Lisa Gurton.
Good afternoon. I'm here and I am by myself in my home.
Thank you. Dr. William Brewster.
Bill Brewster, VP New Hampshire. I am by myself and I'm in Hooksett, New Hampshire at my house.
Thank you, Doctor. Nancy Papp.
I'm in Wolfboro, New Hampshire at our agency headquarters in my office by myself.
Thank you. George Chait.
I am at my home in Croydon, New Hampshire, and I am by myself.
Thank you. Jim Roche. All right. Geraldine Vaughn. All right. Kelly Bryant. You're muted there. Hold on, let me unmute you. Try one more time. We're asking her.
Okay, there we go. Hi, I'm Kelly Bryant. I'm working at my office in Auburn. I am alone because there are other people working in the other part of the building, but here I am.
Thank you. Bob Quinn. All right, and Christy Merrill. All right, that is it, Senator.
It's possible you had Ed Butler rather than Mark Butler.
Oh, yeah, it does. All right, there you go.
Okay, so I will go. I'm post as Ed today. Mark Butler, I'm in my home by myself.
Thank you, Mark. All right. There you
All
go.
right. Thank you very much. And thank you everybody for joining and taking the time. The agenda, just to summarize what we'll be doing today. Number one, the insurance department will have an update on the 1332 waiver. We'll receive that from Commissioner Nicolopoulos and Mr. Sky. Number two, we're going to have carrier comments and input on the market and COVID's impact on the market. Number three, we'll discuss market evaluation ideas, including small group market concerns. Number four, we will receive public input, if there is any, including from advocates and consumers and other interested parties. And finally, we'll discuss an interim report that's due November 1. Any questions or comments or concerns or anything before we jump into the agenda? All right, hearing none, I will turn it over to Commissioner Nicolopoulos and David Sky to give an update on the 1332 waiver that was required in the budget process and was submitted and granted. And then also, I think part of that will be an update on the number of covered lives pre-COVID versus the current market. So thank you very much, Commissioner, for being here, and Mr. Sky for being here as well. And I'll turn it over to you.
Thank you, Senator. So just a little bit of background. At the last commission meeting in January, this commission expressed support for our 1332 waiver application to implement a reinsurance mechanism for the individual market. I'm happy to report to you that the waiver application was approved by CMS on August 5th. Just as importantly, the mechanism has resulted in an anticipated premium reduction in the individual market. While the department is prohibited from releasing rates until carriers make them public during open enrollment, I will say that the 2021 benchmark rate plan has an expected premium rate of $318.95. This premium represents a 21.2% decrease from our 2020 rate. The premium rate decrease for plan year 2021 can be attributed in part to overall market trends, but the timing could not be better as we respond to this COVID emergency. The overall goal of this effort was to lower premiums for the most price-sensitive population and improving the risk pool of the individual market. I'm happy to report, at least so far, COVID has not had a substantial impact on membership in our commercial market. The slide I'm showing, and I believe Tyler is going to do that for me. Perfect. The slide I'm showing was presented at our hearing this morning. I know you'll be asking carriers about their projections for the future, so I'll defer to their comments on potential changes. I'd like to add, the waiver approved by CMS is for 5 years. This arrangement with CMS allows New Hampshire to modify the model year to year in order to address coverage shifts from unanticipated changes. This is a significant win for New Hampshire, and I'm happy to provide some good news with all the challenges that we're facing today. From here, I'm going to defer to my Chief Life and Health Actuary, David Sky, who's on this call with us. David's here to provide additional detail on the waiver mechanism, assessment, and operations going forward. David?
Thank you, Commissioner. And thank you to the Commission for having us today. I think the good news is that when we were last before the Commission and presented the waiver to you, that everything is going as planned. And what hopefully what you hear from me today is really not anything different than you heard from us. What was it, 6 to 8 months ago? Just a little bit of background or history. The individual market, while very small, is a very important piece to the insurance coverage pie here in New Hampshire. And the state has a long history of supporting the individual market, starting with tax exemption for the blues, a high risk pool, and then the ACA transition reinsurance program. The individual market has about 50,000 lives. 40,000 of those get their coverage through the exchange. 10,000 get their coverage off exchange. About 30,000 get some form of assistance with through a tax credit from the federal government and paying their insurance premium and on the exchange, and the remaining 11,000 in the exchange and maybe another 5,000 off exchange are paying for the cost of coverage out of their own pocket. The 1332 waiver process that the federal government has instituted encourages states to use innovative strategies to address the state's unique circumstances and to ensure residents have access to quality, affordable health insurance. New Hampshire's waiver provides for the implementation of a state-based reinsurance program for the reinsurance for the individual market, which is funded in part through a assessment against the broader market and funded in part through federal pass-through savings. We were first exploring a 1332 waiver in 2017, and then after hearings and due process, this particular waiver application was submitted in April 2020, and as the Commissioner indicated, the waiver is for a 5-year period. The reinsurance program will be administered by the New Hampshire Health Plan. How it works is there will be an assessment against the broader market of $2.43 per member per month in the first year. This is expected to generate approximately $13 million of funds for plan year 2021. And because these funds are expected to reduce high cost claims and hence their premium savings, the leveraging with against the tax credits that the federal government will save, we expect approximately $33 million for plan year 2021, and these pass-through savings or tax credit savings from the federal government. So with this available money, approximately $46 million, the estimate is that that this program will be able to provide 74 cents on the dollar for claims incurred between $60,000 and $400,000. Because the program is designed to expend all the money, those numbers might change a little bit based on actual results, but that's the expectation right now. We estimated, or it was estimated that that this program would reduce premiums by approximately 16%. And as the Commissioner mentioned, the benchmark plan, the second lowest cost silver plan premium from the prior year to this year looks like it decreased, or is anticipated to decrease about 21%. Looking ahead operationally, the federal funding will be known in approximately April 2021. The federal government will provide a projection in November or December of this year. Claims will come in throughout plan year 2021 from the carriers, with an initial payment of approximately 80% of the estimated reinsurance allocation for each carrier to be paid by June of 2022, with a true up the following year after that for any runoff claims. The assessment rate is based on the second lowest on the special plan that the Commissioner referenced, the second lowest cost silver plan, and in theory is already known for plan year 2022, although it's not publicly available. And once open enrollment begins, that liability for plan year 2022 will be known, because that rate will be known. Some modeling will need to be done to predict the pass-through funding anticipated for plan year 2022, and that work will be done by the New Hampshire Health Plan. The department recognizes that this committee's role and thinking about this mechanism and our markets, and we publish a lot of data analytics on our markets, and we're always working on these data analytics. One area we're looking at is including CMS risk scores in the analytics for at least ACA plans. And, you know, we look forward to working with you and providing you whatever information we can to help you make informed decisions. You know, my takeaway, I was asked to say a little bit about the impact of COVID on our markets. And at today's hearing, and what the commissioner just showed as a slide, you know, we did see there is some small decrease, and this is sort of confirmed by the New Hampshire Health Plan that collects assessments against from carriers to fund Medicaid expansion remainder amount and what will eventually be this reinsurance program. And we saw that in the first quarter for this year, which that the covered lives went from 502,000 to 495,000. But still that first quarter was a bit larger than the preceding 4 quarters, which had averaged 494,000. So it's very difficult to say whether there's been a drop off due to COVID, because overall, looking at least the past 5 or 6 quarters, there doesn't seem to be any significant drop off. There are a number of national models. Some of them were referred to this morning. I looked at a Milliman report that talks about calendar year 2021 changes. These are national estimates, and it's difficult to say whether or not it would hit New Hampshire the same way based on their New Hampshire model. But they are predicting, this national model for Milliman is predicting a 3 to 7% drop in employer-sponsored insurance, with a corresponding up to 10% increase in individual market enrollment, and a 3 to 9% increase in Medicaid enrollment, and a 4 to 18% possible increase in the uninsured. Those are very wide ranges, which just suggests how uncertain the impact of COVID is. We'll be getting the second quarter's assessment numbers for the New Hampshire Health Plan are due November 15th, and we'll be looking at those closely, and we'll certainly let you know if there's any significant changes from what we're seeing. That's all I have. I'd be happy to take any questions or turn it back to you, Senator Feltus.
Thank you very much, Mr. Scott. Commissioner, do you have anything else that you want to be good? Okay. We'll open it up to questions. We'll start with any questions from voting members of the commission, and that would largely include Representative John Hunt. Representative Hunt, do you have any questions of the department?
No, I was attended the morning presentation, so I'm pretty much up to speed on the stats.
Great. Thank you, Representative Hunt. Anyone else have any other questions for the department on this call? And if you want to chime in, unmute and identify yourself and who you're affiliated with. Seeing none, I got a couple. David, you mentioned that you'll get data on uninsured with respect to the second quarter in November. Is there any preliminary data?
Not any hard data. You know, the commissioner does have biweekly calls with the carriers, and I would characterize those. Commissioner can jump in, but I would characterize those as we haven't heard anything alarming or anything to suggest that significant changes are coming.
Commissioner, do you have anything? You don't? Okay. At least within the 2019 preliminary report of healthcare costs, premiums, and cost drivers were listed as having the highest rates and deductibles in the region and some of the highest in the country. What's the impact on that with respect to consumers? And have you seen an impact in COVID?
To us. You're cutting out again, Senator.
Oh, okay, let me try it again. At least in the preliminary report of healthcare premiums and cost drivers, it's listed, I think it's slide 9 or 10, that we have the highest deductibles in the region and some of the highest in the country. What kind of impact is that having on consumers, particularly in COVID?
So I'm going to take a shot at answering the question. We just need to be careful because we've got both computers in the room and hopefully we're not getting a big echo. It is something that's been recognized in New Hampshire for a number of years, the high cost sharing that is out there. And we actually focused on cost sharing at the hearing several years ago. It's a lot more relevant now because there is a real interest in making sure that people get access to services when they're going to be uncomfortable going in to see visits in person most of the time. And I'm happy to say that the carriers actually stepped forward and in most cases waived cost sharing as it relates to telemedicine services, even beyond the requirement that was in the governor's executive order, which was to waive the cost sharing for telemedicine services when it was related to COVID. That being said, I think cost sharing is sort of the other side of a hydraulic. So to the extent that premiums are going up, one way to offset that is to increase cost sharing. When we did focus on this topic a couple of years ago, some of the feedback was, well, there are ways to get around high cost sharing, but sometimes it's embedded in the complexity of insurance benefit designs. In other words, if you can encourage people to use the system more effectively, more efficiently, more cost effectively, then perhaps they can avoid some of the cost sharing. And that was going to perhaps particular sites where they wouldn't face their deductible or the full cost sharing amount that might exist under other circumstances. And this may be something that the carriers want to comment on more specifically as well.
Okay, thank you very much for that, Tyler. We do have the carriers coming up in carrier comment section. So if that is something that carriers would like to on, please, comment on that in the carrier section. I just have one last question for the department in terms of costs, value-based cares. What should be our goals with respect to value-based care and bending the cost curve? Of course, the carriers can comment on this when we get to the carriers, but if the department would like to comment on that.
Yeah, I will. It's, to the extent we think about value-based care, and I think there are a number of interpretations for that, but the primary one we're looking at is moving away from a fee-for-service system that simply rewards providers based on actually how sick their patients are and how many more services they provide. The department a number of years ago actually did some specific work on alternative payment methodologies, including those that might consider more of a population-based approach. We did an environmental assessment to understand what was taking place today. Among that was interviews with providers and carriers and looking at the underlying data. We followed up with a legal analysis of barriers that might be in place in the state and identified some options there. Finally, a third report was produced that actually had recommendations for New Hampshire. These weren't recommendations coming from the insurance department, but from a contractor we hired. Even this morning, we actually brought in a speaker, Paul Ginsberg, who is well known for looking at alternative payment methods and moving away from fee-for-service. And he had some great ideas, I think, for consideration. He didn't suggest that the state act in any specific way. He recognizes that Medicare is at some level the elephant in the room, and he plays a key role with that. But I think that the good news is, at least from a transfer of risk point of view, and that was shown in the slide this morning, it does look as though there has been some developments in New Hampshire. I think the other thing is that clearly if we're going to rely on fee-for-service, then it's going to create a certain amount of unpredictability for the providers. And indeed, if we have a pandemic, nobody shows up, that's going to create a real troublesome financial position for those providers. Whereas if they had a steadier flow, were more interested and more focused on population-based care or value-based treatment, then perhaps their revenue streams would be a little bit more predictable. So while it was recognized there's a lot of insecurity about the provider financial position right now, perhaps this is something that there is some potential for going forward. So I'm sure the carriers may want to add to that.
Great, thank you, Tyler. Is there any other questions for Commissioner Nicolopoulos, Mr. Sky, or Tyler Brandon on the presentation? Seeing none, we're going to move on to carrier comments on the market and COVID. And we'll just go one by one. And why don't we save questions until the end? We'll have each carrier go through their presentation and then have some questions at the end that the carriers can all address if they so choose. So let's start with Anthem. Lisa.
All right. Thank you very much, Senator. Hi, everybody. We were given some, sort of broad questions in advance to be able to bring our perspective on changes we're seeing in the market. So I'll just run through what we've seen in terms of membership shifts this year, high-level assumptions we're making for 2021, and then really the kinds of changes, if any, that we're seeing in health status of members, and also the nature of the services being received. So I would say at a high level, we have not seen a significant movement from the group market to the individual market. If you look at special enrollment period year over year, we're up, but just slightly, by a matter of a couple of hundred. So we don't see a massive shift occurring in that sense. I was surprised this morning to hear at the presentation that there's no real evidence that the group market has contracted a whole lot. Where we're seeing that show up is an in-group change. So we are seeing significantly more negative in-group change, which means the groups, we're not losing the group, they're staying there, but their membership base is shrinking pretty significantly. I'm talking a couple of thousand, at least a couple of thousand. And that's in spite of the fact that, we try to relax underwriting policies and guidelines to allow companies to keep furloughed employees covered as long as possible. But I would say that's the major place that we're seeing an impact from COVID and from the economy. And in terms of where they're going, if they're not really showing up in mass in our individual book, we heard certainly that the Granite Advantage Medicaid enrollment is up. Standard Medicaid is up, probably the uninsured is up. But for us, we know more about what we've seen go away in terms of our intact groups than we do know about where they've landed. I think our assumptions for 2021 in terms of membership, it will be all about the economy. I mean, I think our current hope and belief is that the dip we saw this year that's directly related to COVID and the economy would come back. It won't be more, it won't be less. I think restoring that membership is our basic assumption or hope, I guess I'll call it at this point. Utilization is interesting. I'm going to share a few statistics in a minute about what we saw in terms of utilization dipping and now what we're seeing as far as it returning. There may be some pent-up demand, but we do think a lot of what went away will not necessarily come back fully. It will just be sort of lost care. Although when you think about, delayed care and the potential for that to affect health, which I'll talk about again in a moment, we certainly could see something there. And the biggest category of potential new cost will be on testing and vaccines. That's big and it's looming out there. And I think we're all trying to get our arms around when and how much and how much it will cost. If you look at the changes in health status of insured members, we're still working with a very short time frame. So we've not seen any evidence of it showing up yet. I think, of course, the period of time when preventative care services were suppressed could have an impact on people's health down the road. And, that could also show up in things like delays in cancer diagnoses or treatment, delays in treatment for cancer care, worsening of chronic conditions if there was any interruption in care. So I think those are the things we'll be watching, but it's just simply too soon to tell whether there's any direct impact to health status at this point. If you look at where we saw reductions in care, it varies pretty widely. So preventive visits in March and April were about 25% of normal, but they are back to about 95% of normal and really haven't at this point compensated for that loss of those months when those preventive visits weren't happening. So 95% of normal, but no actual bubble from those months when we didn't see the normal volumes. Likewise, pediatric vaccines, they went down to about 20% of the norm for 3 months. They're now back to about 95%. That's fairly common. Outpatient surgery was about 20% of norm for a period of a couple months, back to about 95% today. Inpatient hospitalization, as you might expect, wasn't down quite as much because if you need it, you need it. So, but it was still about 40% of the norm and is back up to about 90% of the norm today. Just a couple more points that may be of interest on telehealth. Certainly medical, there was a really rapid flip to telehealth in the first 2 months, but we are back down again on the medical side. So medical has shifted back to more in-person visits than behavioral health. Behavioral health is interesting because it also flipped rapidly to telehealth. And visit volume really remained steady. It shifted, so it was 90% telehealth, 10% in person, but the total volume of care never really went down. And it's kind of stayed there. So today we're seeing about 80% of behavioral health happening through telehealth. But interestingly, the total volume at this point is actually up to about 115% of normal because we are all so stressed out because the world is so insane. So, I mean, that's the one place where we're actually seeing significantly more utilization. And then another interesting one is ER, which at its low point was about 40% of the norm and is now back up to about 85% of the norm. And, you know, I think that's an interesting one because if you were getting care in an emergency room during that period of time, you pretty legitimately had an emergency. So that was probably one way to think about true emergency care and what the actual demand might be. So I think those are the main points. We really question that the catch up that will or will not occur. You know, I think we've got to give a lot of credit to providers and hospitals that have been innovative in terms of trying to get back to normal using, you know, social distancing and sanitizing and extending their hours so they can spread out their patients. So I think those things are helping, but they also in some ways limit the number of patients you can serve at a time, which may also be keeping that total visit count down somewhat. So I'll stop there. I don't think I have anything to add to the questions earlier. I thought Tyler explained it well, but that's all my prepared comments and I'll be happy to answer any questions at the end.
Thank you. Thank you very much, Lisa. Really appreciate it. We'll go on to Harvard. Bill.
Thank you, Senator Feltus. The question or topic was around COVID testing, treatment, and overall use of services. So as you can all imagine, everything changed mid-March for us. We came out early with not only per the executive order covering COVID testing without any member out of pocket, but we also went on to allow for any COVID-related treatment to also be without any member copay, deductible, and the like. The COVID testing, so far we've spent about $2 million on COVID testing for our members in New Hampshire. We've done about 25,000 COVID tests on 82,000 fully insured lives that we have in New Hampshire. So about 1 in 3, though certainly some of them will have more than one. We actually have one member that we're looking at in Connecticut that's had a test a week and has had 25 tests. I was happy to see that wasn't in New Hampshire, but again, one of those things that bears looking at. We are currently spending about twice as much on COVID testing as we are on ambulance transfers. COVID testing is around $8 PMPM. Ambulance transfers, ambulance expenses are around $4. And we've started to see the COVID testing actually go up a bit, partly I think because of the kids being back in school, the universities back and increasing rates of COVID. But also I think that one of the things is I think Lisa may have mentioned this, almost every elective procedure now, you're getting a COVID test before you get that test done, appropriately so, because certainly having COVID and going into a post-operative period is not a good combination. Our claims dropped off dramatically. They were somewhere around 54% of usual in April. Dollar-wise, they've rapidly went back up. So in June, we were almost at 100%, and we've been at 106, 102, and 110, with 110% of usual historic claims dollar-wise as of September. We saw a fairly dramatic drop-off in ER. Our ER visits per thousand, we were about at 56% of what we would have expected to see for April. We're now back up at 105% of what we would have expected to see in September. And about 30 of those are what we would have considered to really not be emergency room kinds of things. So there's still an issue with people getting access to routine non-emergent care in places other than the ER, which of course is a much more expensive and potentially clogs the ER with things that aren't appropriate. Inpatient was down. That has come up significantly. Surgeries are at 105%. We went from a high of 65% of our office visits being telemedicine back in April. That stayed about there for a little bit, went up to actually 98% in June, but has dropped off significantly to 29%. And as Lisa mentioned, whereas actually it was about 73% was the high, and we've seen behavioral health visits go much higher than 100% of what we would have expected to see. We've seen telemedicine replace and continue to replace. So the use of telemedicine in mental health is not dropped off at all, which again is a good thing. I mean, I think people can get access to care that they couldn't get or didn't feel comfortable getting before because they had to go in person to somebody's office. So we're happy about that. We've always paid on par with an in-person as far as on the behavioral health side. So there was never a decrement for seeing somebody by telemedicine, but it was frustrating because we could not get people to use it. So we're very excited that people are able to get access through that. One of the things that I've been really concerned about, corporate's been concerned about, is our immunization rate. Our immunization rate dropped off to about 60 to 70% of what we would have expected to see. My director of network contracting is the chair of the immunization board, and she said that that's about what the state had seen. The good news is we've seen our preventive care services, which had dropped dramatically. I don't have the exact number here, but about in half. And we're now at about 132% of what we would have expected to see this same time. That includes immunizations, colonoscopies. That's the good news. The bad news is that Maine, Massachusetts, both of our markets there have come back up to around 155%. So we're still seeing, we're still lagging a little bit, although we seem to be catching up. One thing that we decided to do and announce this week was, despite the fact we pay a premium to assessment to have kids get immunizations free, we decided to go ahead and open up the doors. And so we've included any participating pharmacy can now give kids 3 and older immunizations and at no cost. So we'll cover the cost of that as well. We just desperately are trying to not have what we saw happen in Massachusetts, where we had a child with pertussis, whooping cough at the same time they had COVID. So we're really trying to get people back in. I did an op-ed in Union Leader recently to just say, look, call your office. They're open. They'll see you. Don't let things go like colonoscopies and all. As much as I love having a colonoscopy and just looking for an excuse, don't use that as an excuse, because you can get in. Yes, as Lisa said, the throughput has got to be slower because you have to go through the gauntlet to get into the ASC, but it is still there. I don't think that I have a whole lot else to talk about. Again, we're still covering treatment and testing and plan to do so through the end of the year with no member out of pocket. So we're hoping people still get tested. We want them to. It looks like they have been. And I guess any questions anybody has, I'd be happy to answer, but that's all I had.
Thank you very much, Bill. Appreciate it. Appreciate the update. Tufts, go to Tufts.
Senator, I believe the representative from Tufts had a emergency this afternoon and will not be presenting with us. And unfortunately, it was at the last minute they weren't able to get somebody to stand in. Gotcha.
Thank you, Commissioner. Cigna.
Yes, good afternoon. Thank you for the time. Very much appreciate the forum here and comments from the other plans. But first of all, I want to start off by saying, as we work through this crisis, it's probably one of the best efforts I've seen, collective efforts between the health service companies, the Department of Insurance, employers, hospitals, physicians, the balance that I think everyone maintained, and I'll specifically address the department here, throughout this, I think was extraordinary. If we go back to the middle of March, it was a very difficult period, I think, for everybody that sits in this call today to try to figure out, number one, where are we? Number two, what's the duration? What's the severity of this? And I think now that, we're 6 months into it or 7 months into it, depending how you want to look at it, some of what we do today seems rather routine in an unroutine environment, but it didn't feel that way at all back in the middle of March. So thanks to everybody, all of the different stakeholders, and collectively, I think all of the health service companies working with the department on this phone, I think we've done a real good job with the residents of New Hampshire, and I think we found a good balance there. I'll try to supplement around a little bit, probably cover some points Lisa and Bill covered, but also try to maybe bring a couple of different perspectives in. Number one, I would say just when we look at the severity of COVID, let's just start there. The Northeast was dramatically less impacted than many of the other areas in the country. And I think if you look collectively at the work done inside of New Hampshire, the quick response, the thorough response, the decisiveness of the response, that's why we sit in a much better place today than a lot of the other states across the country. When we look at overall utilization impact, much less in the Northeast, much more significant when we look at it in Cigna nationally. So again, I think that's representative of the work that we all collectively did. In terms of the shifts happening in the market and just about COVID testing in general, to touch on those, I agree with the comments of the prior speakers. What I will say is, Cigna was first to the market on waiving cost share and associated care around COVID. We're proud of that because not only did it help impact the people of New Hampshire, but we established a very consistent national protocol. And as most of us know, many of us have companies that set up their situs and their headquarters in New Hampshire, but they have employees all over the country. So to have consistency in those protocols and consistency in how we're approaching that from a cost covering perspective is very important. And when we look at that, it becomes important. Most of our book within Cigna, largely nationally in this region, is self-funded. So employers are paying for our administration, but we're actually managing their claim expense dollars. And then we also have fully insured business. But we thought it was important to have a consistent protocol that reached across those various funding types. And again, by and large, I think all of the organizations have done a very good job of addressing that. When I talk to employers today, and I think this is significant as we sort of think about where are we today, what happens if we have another surge? What I would sort of headline it is this way. One, most employers, I think in general, had to make some modifications in terms of, in-company reductions, not all. Number two, I would say most employers, virtually all, I think really tried to do the right thing. There was an emphasis on maintaining coverage. They knew it was the right thing to do. They knew it was an important thing to do. And when we think about people accessing care and testing, you know, for everyone to lose coverage, really would have made the disaster even worse. So I think employers, by and large, really did the right thing, and they should be very proud of how they stepped up to maintain that continuity of coverage. From an industry perspective, there's certain industries that have been really, really impacted. So when you think about the hospitality industry, you think about the smaller employers, you know, the small restaurants, coffee shops, those types of things, hospitality, some manufacturing. The impact of COVID has really varied by company sector. The higher education, which as we know around New England is a big part of what we do along with healthcare. Those folks have had to do significant multiple scenario planning that can range all the way from a full opening to partial openings to fully virtual. They've really done a great job, but they have been under a lot of stress when you sort of think about the balance that we've had to maintain. What we do view as a very positive thing, and the two prior folks touched on this, telemedicine services have increased significantly. When we talk to the different hospital and physician groups across New Hampshire, that'll be one of the first questions they'll ask me. Is it here to stay? Is it going to go back to sort of pre-COVID levels? And I think we've heard from the prior speakers, it's here to stay. I think COVID we would view as an accelerant, probably one of the positive accelerants. When we look at medical services today, you know, we were largely very low single digits pre-COVID. Went up as high as, you know, 40% televisits during COVID, settling back down into, you know, kind of high double digits. And I think it'll stay there. I think the successful physician practices that have pivoted to the use of telemedicine have found it to be successful. And I think the number one thing that they've felt is that it's solved the no-show problem, the patient no-show issues that they've had. Now, if you look at a lot of the studies that have come out recently from J.D. Power and others, telemedicine has some issues with it, right? So we saw a little bit of it today with our Zoom session. There's still a lot of technological bumps that take place during televisits. There's still some sense of confidentiality concerns that go with that. There's the cost factors. So there's more work to do there, but I do think people through COVID have found that the convenience of getting care in their home, whether that's traditional medical services or behavioral health assessments, has been good. It's convenient, and I think that will again continue to provide really an acceleration in the virtual space. I do want to touch behavioral just for a second. When we look at the duration of this issue, okay, there are two things that are going to begin to take place. Okay, number one, we're going to realize this is going to be a way of life for some time. That might be where we physically work. That might be how we work. And the issues around loneliness are going to become accelerated. There's a lot being written, a lot being talked about right now. Many of you are familiar. We just put out a very significant study around loneliness and the impacts that has on the workforce. The long-term impacts that we're really going to have to address is how do we make ourselves more resilient? What do we do? How do we change as a company? How do we deal with our employees that we can't physically be with or see every day? So the durational aspects of this and the behavioral impact of that tied in with traditional medical conditions that we manage are going to become multiplicative as we go forward. And that should be a big concern when we think about, you know, additional cost burden inside of the healthcare system. So, you know, I'll conclude. Again, I think the other speakers talked about some of the usage issues, fairly consistent with us. But I think as we look forward as a health services company, you know, sort of the traditional work that we've done, we've always been very good at chronic condition management. In those types of areas of lower back and those types of things, cardiology. We're really going to have to think about condition management being in the behavioral health space as we go forward. There's a shortage of behavioral health providers already. And this is going to really put additional tax on the system. We're encouraging employers, everybody to really think about, you know, their long-term strategy, having a very clear, very consistent, very available resource-driven strategy around behavioral health as we go forward, because the overall tie back and overall medical cost is going to be significant. Appreciate the time.
Well, thank you, Mark. Really appreciate it. Appreciate being here. Appreciate the comments.
Thank you.
You got it. And better. Do we have any?
Senator, thanks for the time.
Oh, yeah, okay.
That's me, Senator.
That's right. I forgot.
Vice President of External Relations for New Hampshire Family Member. That have already been my counterparts here. Obviously, utilization trends, we've seen a lot of the similar trends. We were down at the apex, of the initial pandemic in April and May, about 50% in terms of overall utilization, and that's across both product lines, by the way, in the individual market and in Medicaid. That's largely back. I think we're almost 90% of pre-COVID levels in terms of utilization. One of the interesting components within that utilization, as Mark just referred to an awful lot, is behavioral health and telehealth. Telehealth makes up about 12% of the within our marketplace. That's about 15,000 members on the individual market. Makes up about 15% of total claims right now in our total Medicaid membership. That's about 80,000 members on Medicaid. But overall, within that behavioral health utilization, or that telehealth utilization, 55% is behavioral health. And so as Mark talks about, in terms of policy considerations going forward, how we really, utilize and right-size access to telemedicine, especially with regards to behavioral health, I think is a really important question to adopt. One of the most expansive telehealth laws in the country. I think that was an important thing to have done at the time. I know I think there's a corresponding study commission that goes along with that telehealth legislation that provides with a number of and I think as we go along and understand the utilization better around telehealth, and again, behavioral health in particular within telehealth, it's really conducive to all of us to have a comprehensive public policy discussion on what's the right fit there. Obviously, again, just by the statistics that I just cited, we are seeing an uptick in behavioral health utilization writ large, and obviously, I think you can associate that with a number of pandemic-related conditions, isolation, a number of factors that some of my colleagues have mentioned. But overall, I want to laud New Hampshire's public policy response and regulatory response to the pandemic. I think David mentioned at the beginning that at the inception of the pandemic, the insurance department started bi-weekly calls with dealers to understand the realities on the ground and what the carriers were seeing real time in their utilization data. It allowed us to really be nimble and adapt to quickly evolving sets of circumstances. Again, I'll just say a lot of the carriers, including us, have been very proactive in terms of what we've done, eliminating barriers to care, making sure that we were eliminating prior authorizations to teleservices, not just COVID related. We took great care to do that. We came to the table, Senator, with you and other members of the legislature to build in tandem with providers, to build in grace period on prior authorization, to work on Senate Bill 1639, as you know, allowed for services that had been authorized prior to the pandemic to remain authorized for a period of time, after which hospitals and providers were allowed to engage in procedures. And I think that was an important response as well. So overall, I think the regulatory and public policy response here in New Hampshire has been extremely agile. Again, I thank the commissioner and his team for working with us very closely, all of the carriers, the industry very closely, to try to ascertain the greatest level of predictability and stability that we can in an industry that we know craves stability and predictability. So I think I'll leave my comments at that and happy to answer any other questions.
Thank you very much, Chris. And thank you for all that you're doing. Is there any questions from voting members of the commission? That would be Representative John Hunt. Representative Hunt, do you have a question of any of the carriers?
No, not at this time.
I have one question. Mark, you mentioned, and certainly it is an issue, the lack of behavioral health providers. What suggestions, and we can go through each carrier, if you have input on it, what suggestions do you have, public policy suggestions, to bolster the supply of behavioral health providers?
Yeah, that's a great, thank you, Senator. Maybe just a couple observations, maybe just to level set it. So I think despite the good work that everybody has done at the employer level, health service company level, physician level, there's still more work to be done to neutralize the stigma that goes around behavioral health. So when we think about the access or the availability of providers, I'd like to say, just take a step back, just one step, and say there's still a lot more work that we need to do to educate individuals that it's okay to come forward and get help. That could be coming forward to your employer, coming forward as an individual, that it's okay. So that's sort of the grounding point educationally. Second piece, more specifically to your question. So there are plenty of fine available, we'll call them in-network providers that exist. There's current relationships that are very happy. Reality is a lot of those panels are full. Okay, so that's where we run into some problems, but there are a lot of people that are currently receiving behavioral health care. They're very happy with those treatments, and those relationships are very positive. Where we are going to, and where we need to see a shift, is to continue to get people comfortable that it's okay to use some type of virtual behavioral health organization to intake you, to assess you. At Cigna, in addition to the National Behavioral Health Network we also have a relationship with a company called Talkspace. And what that does is it actually allows us to bring virtual care back to those patients. Theory really being, I think, as we go forward, this was true pre-COVID, but it's very true post-COVID, is enjoy the ability to get care in the comfort of your own home. Very relaxed setting. You haven't got to drive somewhere. The challenges that are going to continue to exist, particularly in the urban areas. So if we come out, break New Hampshire into a couple of different pockets, as you come down into some of the more major cities in New Hampshire, there's still hesitancy of people to seek care in densely populated areas just because of the social distancing. So I think the work and the affiliations that we have that can bring more virtual care, that becomes a very acceptable and probably a very needed extension of the contracted provider networks that we all have as companies today. Because as I mentioned in my opening comments, this is going to get more significant rather than less significant. So if you think the behavioral health system is taxed now, if we look at the duration when we have something the size of this pandemic, the long-term repercussions behavioral health-wise are not in the matter of months, they're in the matter of years that you're managing this. So there's going to be a very long tail. I think virtual networks and accessibility to those networks is going to be critical.
Thank you, Mark. Is there any other carrier who would like to weigh in on this bill?
Sure. Thank you, Senator. Like Mark said, I think telemedicine is one of the answers to it. As I said before, we've tried to encourage people to do that because then the throughput, there's missed appointments, the geography, the weather, things in the North Country, I know when I practiced in North Conway, everybody knew what you were going in for when you stopped at a particular building, whether it was in Jackson or Conway. And that stigma, as Mark said, is still very real. So telemedicine lets, particularly adolescents, stay at home, be on their iPad, do whatever. We offer all of our providers in our behavioral health network a free software tool that allows members to go on their site, schedule an appointment electronically, be able to see them. And just like primary care, which is equally unavailable, we have a huge issue with primary care having open panels in the state. I think telemedicine is going to open up. It's going to allow people to be more efficient with care. It's not right for everybody, but it certainly could be better for many. And telemedicine also takes what might be an actual problem with the number of providers in the state and makes it so it can go across borders. There can be people who are located anywhere and do telemedicine. As long as they're licensed in the state, they can do telemedicine. So that ability to spread out, because it's not always that there's not enough providers, it's just they're all in metropolitan areas. So that takes it away. I think the other thing is, unlike primary care, where almost everybody is in our network and basically wants to contract with us because they're employed physicians, when you look at the behavioral health side, they're almost all independent physicians. So for them to want to contract with us, it's like, yeah, no, I'm going to charge cash. I mean, for an example, I knew someone just came out of an employed position related to COVID and layoffs, a psychiatrist in New Hampshire, and I spent about an hour and a half on the phone with our behavioral health medical director and myself, basically promising the world, begging him to get into our network because that particular area just doesn't have psychiatrists. And again, I think his ability to use the network to do telemedicine, I think that's really going to free up time for the ones we have and also allow us to use docs that normally wouldn't. We also have an app called Doctor on Demand, which used to be an urgent care medical kind of thing, but now you can schedule behavioral health visits as well. And you can pick the same provider. So it's not a random provider. If you want to have a relationship, if you had a great call with somebody, you can reschedule with that same provider.
Thank you, Bill. Appreciate that. Any other carrier want to weigh on the issue of the shortage of behavioral health providers? Or anyone else want to weigh in on the topic?
Senator Mark Butler again. I just want to make one real quick comment. One of the things that COVID has done is it's redefining for employers where they can hire individuals. So as we sort of think about traditional relationships, you know, you want to live and work 20 minutes from where you got to work and where you're going to live, right? In today's world, particularly in New England, you know, which is not inexpensive, as all of us know, what COVID has done is it's proven to employers that they can hire people anywhere in the country, anywhere in the world, really. So as we think about sort of traditional network configurations and workforces, we need to think about that differently, that we may be hiring people in extremely rural areas, as Bill just pointed out with that individual. And access to care may not physically be going into a provider's office and working with them. It might only be able to be delivered based on where those employees are living now, virtually. So there's really sort of a reconditioned thinking that we've all got to go through, that when we think about, you know, sort of these traditional assessments of how big is your network, what do I have accessibility to? I believe that COVID is going to really kind of change all of that and let us, you know, candidly rethink work. And then we're going to have to rethink how we deliver services to people.
Thank you, Mark. Any other input on this question? I did have one final question for if all the carriers could just jump in on this. The question that I asked, I think Tyler, the impact of deductibles, having the highest deductibles in the Northeast. There's a brief conversation about cost sharing and whether it incentivizes or doesn't incentivize the proper use of healthcare, et cetera. But we do have the highest deductibles in the Northeast. And what is the impact in terms of cost sharing and deductibles right now in particular? And are there any concerns or issues that are being raised with respect to that, especially right now in COVID? And why don't we just start from the top and start with Lisa, if we could?
Sure. Well, I thought Tyler hit some of the most critical points in his response. I mean, and I think, it's important to remember how we got here to this point with the deductibles. It's because our underlying cost of care, our overall premiums are so high that buying down has been one of the, levers that employers have had to pull, or we've had to pull, on plans to make them even somewhat affordable for people to buy. And it's certainly a trade-off. So I think, we can't forget those two things are completely connected, and solving one is really the only way to solve the other. I think in the very short term, as we pointed out, we know that preventive care services aren't exposed to those things. We know that most of the, COVID services during this period have not been. But in general, do I think that having large cost shares impacts people's decisions about care? It has to some degree. So as Tyler pointed out, what we've tried to do is create at least opportunities to reduce your exposure to cost sharing if you get engaged as a consumer and pay attention to the sites of service, the variation in price that exists. Meaning if you're actively doing your part to try to seek out high quality, cost effective care, it seems only right that your cost share should go down kind of proportionally. It's kind of and if you don't want to do that and you just want to go wherever, you still can, but you'll be exposed to that full cost share. So I think those are the sorts of things that you can do in the immediate term to try to help people with that exposure. But it's all tied up in that same knot of health insurance, healthcare affordability in general. And again, we're just getting there a little bit faster than many parts of the country because of the premium prices themselves.
Thank you, Lisa. Bill, do you have can you respond to that?
Yeah, so we've been struggling with that. I think one of the biggest issues that I want to make sure is that, again, people understand that their preventive maintenance things are free. So we've been really trying to promote colonoscopies and other exams. We've started, we'll be rolling out 3 primary care visits free across all of our products. So you can get into the office of any of your doctors and not have to pay any copay or deductibles. We've worked with one hospital system in the North Country so that they, all of their, any employer that has a particular product with this hospital that we've designed will get free primary care as well. So I think that's one of the things that's really important. We also, for those expensive things, have a couple of different networks that there are product designs around certain networks that people agree to provide lower cost for certain tests. And in response, we have one particular product, which I probably related to the deductibles. It's our most popular product, which is you go into any of the preferred providers and it's one copay. If you have surgery, you don't have to worry about the radiologist. You don't have to worry about the doc. You don't have to worry about the OR. It's one copay. So no matter what your deductible is, it's a low copay for the whole everything related to that. So I think we're trying to work around it, but as Lisa and others have said, it's a response to the high cost of care, and employers are just trying to keep those premiums down. We also, one more other thing, we also have in our small group product now a combined low cost way for employers to offer HRA accounts coupled with it so that they can keep the same deductible for the member. They buy a higher deductible, but they cover the second half of it. So to the employee, there's no change. Anything over what their deductible was the prior year, that's the same out of pocket for them. But the employer covers the second dollars and net they save a lot on the premium. So we've been trying to promote that as well.
Great. Thank you, Bill. Mark?
Yeah, just a couple of quick comments. Thank you. Kind of going off of where Bill just ended up, we've been into and have sold a lot of high deductible HRA, HSA plans for a long time. And we've had very good success with that. I think it's those employers who have committed to that. And when I say committed, it's the education on how that works. It's the employees looking at some of the online tools to make care decisions. Goes back a little bit of what Lisa said, how do you pick a least expensive, high quality care setting to go along so that you maximize the benefits under your program. Bill touched on, preventative care is accessible. It's 100%. So those things are there. So I think there is a lot of good work that has been done across companies. We are still candidly a region that doesn't like restricted choice. And I think until there's larger acceptance at the consumer level that restricted choice or limitation of choice in certain types of products is a more affordable alternative. I think most of us are working on trying to set up highly affordable plans with high quality, driven through key providers. But there has to be a broader acceptance, in my mind, across the general population in New England and New Hampshire to buy into those types of products. We just historically have not been there, at least in my 30 years of being here. And I think the other piece that we just have to keep in mind is that we have been largely a very copay-based area here. And, when you're in a large copay environment, or not a large copay, but in a very heavily saturated copay environment, the consumer has been largely insulated from the real cost of care that we're talking about. So as we sort of unwrap that and the cost of care becomes more transparent to the consumers and to the employers, that's where we see, the perception at least, and probably reality in many cases, of the cost sharing is going up. But we're really unwrapping a long history of $5, $10 copays and $2, $6 drug cards for branded generics. And when you look at the acceleration of cost inside the different components of healthcare, we saw this morning on the report, just specialty injectables as an example. I think the average cost, if I remember the number right, was about $3,300. You can't hide that behind a $10 copay any longer. So I think there's a perception and a reality that cost shares are high. Reality is we're sort of unbundling where we've historically been, certainly in New Hampshire, but really across New England. And I think there's a lot more work to be done in terms of the education of how do you choose the right place of service that's low cost and high quality.
Thank you, Mark. Chris, do you have, can you respond to this too?
Yeah, just briefly, Senator, again, I agree with most of what everybody has said. For us, it's all about eliminating access to care and empowering our members to control their own care. And again, I think in the individual market, we have a story to tell in New Hampshire about premium reduction in particular. I think the presentation this morning suggested that premiums were down in 2019 about 11%, scheduled for a deeper premium reduction for 2021. And of course, with the advent of the 1332 waiver and the reinsurance program, I think there's a real story to tell, but ultimately it's about, reducing cost of care and empowering consumers and our members into things around incentivizing, the right care, right time, site of care, preventive care. For us, we utilize a lot of care coordination and care management to make sure that our members know what's available to them. But ultimately, eliminating barriers to care and making sure our members receive the right care at the right time, and having a broad dialogue with providers. And we talked a little bit about APMs, but having a broader dialogue with providers about what kind of opportunities exist there to offer higher quality, more cost-effective care.
Thank you very much, Chris. Any other questions, comments from the carriers? And thank you for being here. Thank you for providing those comments. Then we're going to move on to a discussion of market evaluation ideas. That's one of the tasks of this commission. I believe what was circulated was a one-page document. You and hopefully have it. But I would like to thank Tyler with the department for helping with all of this and helping with this document. And I'll turn it over to Tyler if you want to go walk through it and throw out some ideas. If you wanted to go through it, we need to just give some guidance to Tyler about some of the possible quantitative measurements and some of the things that the commission wants to look at in this context. So Tyler, if you want to take it away.
Sure, thank you. So before I do, actually, I thought it might be helpful to show people while we were talking about cost sharing, a slide from this morning's presentation, assuming I can share my screen again, because it's interesting to see how cost sharing differs and how little it's changed as a percentage of the total allowed amount. So hopefully you can see that. And this shows you across the markets. I think there are a couple of takeaways. I mean, first of all, it is different depending on what market segment we're looking at, but also that in general, the trends don't show this sort of overall steep increase as you might think, because you think about how deductibles go up generally each year, at least it feels that way. But when you look at the overall cost of care and the allowed amounts, the relative percentages don't change very much. So that's, I think, just an interesting slide from our report. And this is in the preliminary report, which is available on our website now. So I'm going to see if I can switch to the valuation ideas. And hopefully you can see that now here too. And I would say that the insurance department collects most of this data and reports on a lot of it in this report that we just put out. There is some additional detail, as in the number of products by market and things that may show sort of the health of the market over time, particularly if we were to see either major increases or major decreases. There's always a lot of focus on the individual market, and we're always a little bit anxious each year to make sure that we're going to continue with the number of carriers in the individual market. But certainly considering things like the number of products, the relative premium levels, really even the sort of the incentives that may exist for risk selection choices. And those are things we really want to kind of keep track of. So we think this is a good list, certainly something the insurance department, I think, will make a bit of a more deliberate attempt to keep track of. And I think to the extent we are concerned about our markets, it's important not to just focus on the individual market. There is real interest in the small group market. And indeed, some of the decreases we've seen in recent years in that small group market, and hopefully you can see this slide here, that's a bit concerning when you just start to see a continued drop in the small group market, whether or not that's going to be an area where we're going to see some of the competitive, the level of competition we have in the past, and just general interest in offering innovative products there. So maybe I'll wrap it up on that. We do think these are good ideas to keep track of, and would certainly appreciate any feedback from the carriers about the kinds of things they're focusing on and what keeps them in the market, keeps their interest in developing new products, and really kind of investing in the health of our markets overall.
Thank you very much, Tyler. So everybody has the list. I think it's a good list of components to take a look at, both in the individual and small group markets. So is there any feedback on the list of things to take a look at? Obviously, this is an ongoing exercise, but this will get the department going. Hearing none, that's great. It's a great list. So why don't we work from there? And I think, Tyler's already done a lot of work on this. So continue to springboard from this list, I think makes good sense. So moving right along, unless there's anything else on that, seeing none. Public input. If there's anybody watching at home or wherever you may be, in Zoom land or internet land, and you want to provide public input, please so note it.
You can raise your hand via Zoom, or if you're on the phone, you can press *9 and we will see your hand raised and then we will allow you to speak.
Alan, can you just repeat that again, how people can alert?
Yep, no problem. So you should have the option in Zoom to raise your hand in the Zoom program, but if you are not able to do so because you're on the phone, you press *9 and that'll also raise your hand and we will call you and you'll be able to speak.
Okay, we'll just give it a few seconds, and then Alan, why don't you just call on folks and we'll go from there.
You got it. Right now, it doesn't look like anybody's raising their hand. Yeah, we got a quiet attendee list today, Senator.
I heard a ding. I don't know what that means, but
we got Lucy Hodder here. I'm gonna bring her in.
Okay, great.
I wanted to see if this worked more than anything else, and make you all feel like someone's listening out there. Can you hear me?
Thank you for listening, and we can hear you loud and clear, Lucy.
Okay, well, this is great. Thank you all for holding this, and you know, I think that there are so many questions that the public needs to engage in that it's hard to even know where to start. But I'll just ask one quick question, which seems to be very relevant on a lot of discussion groups in the community, which is just how to keep the communication with members and the public going around coverage for testing by employers and various employer groups, COVID testing with or without symptoms. I think there's a lot of questions about that, how that's going to work going forward. And couple that with the questions about readiness for any, if and when vaccine distributions, how can providers and the public engage in making that successful and having questions asked and answered around that process from the carrier perspective. So that's just an initial question.
Thank you very much, Lucy. And Lisa or others of our carriers want to answer that if you can.
Sure. So Lucy, the question is on how do we make sure that people have access to testing and vaccines? Could you just repeat the very first part? I missed something you said at the very beginning.
So the question that comes up often is how are the tests without symptoms? So tests that employers require to come back to work, tests that may be needed to go for a visit to a loved one, tests that are happening as a regular course over time.
Yeah.
People have a high deductible, they're not going to be going to get a test and paying out of their pocket. What happens in the future? What's the coordination around? When are those tests covered by, access? When are those tests covered by employer access? And how to get that information?
Yeah. Okay. That's where I thought you were going. I think we have some work to do at the federal level and at the state level. And in fact, the Commissioner of Insurance actually got some of the payers together with Health and Human Services here in the state to really talk about that, because we know there's going to be this wide range of testing, some of which fits neatly into health plan coverage, and some of which that's either for public health surveillance or back to work really doesn't. It's outside of the scope of what commercial health insurance does. And I think we have conceptual common understanding of that. And, we've been pushing really for CMS, and I think CMS has said the same thing. We need those codes that will make it much clearer which is which, so that we can all do our part appropriately. And I know in the short term, we are covering medically necessary tests with a doctor's signature. I mean, the true intent being, are you sick or are you well? But knowing that it's gone beyond that. And then there are some examples of widespread testing in like nursing homes for employees, continually, that I understand are being roster billed directly to the state, which is great. So I think we are getting there. I think we're right now watching and reporting and looking at what we see coming in. And I think, again, as we get further along jointly on having clear definitive codes, clear definitive kind of billing instructions, we can be sure that we're all doing our part, fully, and that we're not leaving anything out. So I think we'll get there. I still, I remember very naively saying, well, a vaccine's a vaccine, like it will just cover it like we cover all other vaccines. And then I found out there's really a lot more in motion about that and about how they'll be made available, where they'll be given, how they're purchased. So I'll confess, I still have a lot to learn about how all of that will work. I know we've got a corporate team working on it, but I would not personally be able to give you perfect clarity today on how it's going to work once the vaccines are here. It's like who gets them first? How are they accessed? How many options are there? So I'm afraid I'll have to leave it there. But on the testing front, Lucy, I do feel like we're working collectively on making sure that all the pieces fit together and people are getting what they need.
On the vaccination front, I know the National Academy of Sciences, Engineering, and Medicine issued, was like last week, a framework, 5-tier framework of how to deploy vaccinations, but obviously that hasn't been formally adopted by any entity. But the first tier involves healthcare workers and that sort of thing, but you can take a look at it online. In terms of the first response on testing, just to follow up to Lucy's question, I think it is, something that will continue to obviously bubble up. I mean, people have kids in childcare, for example, and, just speaking from my own experience, if there is symptoms of other kids or in close proximity to our kids, or our kids had any symptoms at all, even if it's not traditional COVID symptoms, the protocol is to get a test. And so even though they're not fulfilling or meeting the, traditional COVID symptoms. So this is something that, I think parents are dealing with kids in childcare and in schools. Teachers are dealing with it. So knowing when can you get a test, when is it subject to cost sharing, under what circumstances, I don't think there's not clarity out there. I don't know if the insurance department is going to be providing clarity on it moving forward or not. If that's something that's been discussed, Commissioner.
So we're still kind of coordinating our computers so we don't run over each other. Okay. But certainly the expectation is the vaccine would be covered. We are still working through some of the specifics on that, but a lot of this isn't just a state issue. So it's a national issue as much as it is anything in New Hampshire. So trying to figure out some of the details, we're still, I think, in a bit of a holding pattern there.
In terms of the testing and cost sharing for testing, under what guidance moving forward, whether or not it's traditional COVID symptoms or just an advice to get your kid tested, and your kid has to get tested before your kid gets back into childcare or school, or a teacher, for example, wants to get a test, that cost sharing component and under what circumstances, how is that going to be handled moving forward?
All right.
I think we just figured out how to switch the computer back and forth. It's our view that COVID testing will always be covered when it's medically necessary, and it's my understanding that the treating doctor makes that determination, and there's really no checks or balances on that. And so in traditional payment parlance, we expect that if the doctor orders it, it's medically necessary, the insurers will pay it. The order regarding waiving of cost sharing for those tests, I don't believe we've had a single discussion about unwinding that since it's been in place. So it will stay in place as long as it's necessary.
Thank you, Commissioner. And in terms of whether or not it's determined to be medically necessary, I think that's kind of where some people are falling. It may not necessarily be, quote, medically necessary or advised to be a COVID test with respect to a medical provider. However, for a school or a childcare center to allow a teacher or a student to come back, it may be part of their protocol, even though it may not be considered medically necessary by a doctor. So that is, I think, a gap, or it's certainly an issue. It's a big issue right now. And what is the, if anything, in terms of the discussion where the insurance department is on with respect to that?
I don't think it's an issue right now because, as I understand it, the insurers are paying all of those claims. I think at some point when CMS guidance and coding is sufficient to cover what might be traditionally considered employment-based testing or true just community surveillance testing, there potentially then could have be a discussion about what's the right role for a private insurance, what's the role for a potential employer-driven testing, or what's the state role in kind of general surveillance testing. I think Elisa from Anthem mentioned that we had conversations with the HHS, and it was a great conversation with them because the carriers, absent any coding guidance, are just making payments on those tests. So there will be at some point potentially some discussions about how medically necessary plays into surveillance testing or workplace testing, but that's not something that we've had to address yet. I'm in close contact each week with my consumer team here to see if we're getting consumer complaints about denied payments on testing, and I don't think we've had one in 4 months. There was some initial coding issues or billing issues way back at the beginning of this, but I haven't been aware of one in a very long time.
Yeah, if I may, I would say that having just seen some testing data, and I'm just scanning, I don't have access to it right now. We are paying for a lot of tests. I'm actually not worried we're not paying for enough tests. I think we may be paying for some that truly do belong in a different domain. And that's better in the short term than the other way around. But I think we also appropriately have to be looking out for costs that bleed into what employer-sponsored insurance is funding that have a rightful funding source elsewhere. So I think that's where the codes come in. But in the short term, there is far, far more being paid than denied by an order of magnitude. So I don't have any concerns right now about that.
I've heard from appreciate that. I heard from some teachers on the ground that just based on the policies within their schools, that they were required to, under certain circumstances, get rapid testing or to come back to teach, depending on things that bubbled up on the ground. And so, again, it kind of goes beyond what's quote unquote medically necessary, and it goes to what the specific policies are for people's employment, including teachers and educators and childcare facilities. And I'm wondering, is there any coordination with the Department of Education, Commissioner, on, what these policies are on the ground for teachers and educators in terms of getting tests to re-engage in the workforce? And if it isn't quote unquote medically necessary, but it is a policy, is that something that there's communication with the Department of Education in terms of communication with local school districts?
Thanks for the question, Senator. I've not had any conversations with the Department of Education, in part because I understand that the insurers are paying for all the tests here. And so there are two things that I would take away from your comment. One, there's always an issue that insurance in municipalities is outside of the regulated insurance here at the department. But irrespective of that determination, I would recommend that any teacher who's concerned about the cost of the test or it being covered, feel free to refer them to me directly. I'll connect them to the consumer team. We can start at the top and go down, and my team will call other folks on this call, and we'll determine if it's a regulated entity, how to get that covered, and if it's not, whether or not some ERISA guidance is controlling there.
Yeah.
But again, just to restate, I don't think we've had any issues as of yet with medically necessary being the trigger for non-covered COVID testing.
Thank you, Commissioner, and I think it's not simply just a medically necessary question. It's about the cost sharing question too. Obviously, Commissioner, not just about the medically necessary determination or not, but the cost sharing question as well. And go ahead.
Yeah, so the cost sharing for the regulated entities, we've addressed that. If it's an self-insured plan, there may be, I don't actually know this, there may be self-insured plans that aren't waiving that. But if that is popping up, we have the expertise here to determine why they're falling outside of what we understand to be the landscape that we're living with. And I can't guarantee that every self-insured plan is covering without cost sharing, but I can guarantee that we can get to the bottom of it.
Okay, great. Thank you very much, Commissioner.
No problem.
Bill.
Yeah, I think one thing just to be reassuring, like Lisa said and others, we're covering the tests. As I told you before, they're twice as expensive as ambulance costs right now. That said, moving forward, just like drug testing, I used to run an occupational medicine clinic, and we did pre-employment screening, we did suspicion screening, we did accident screening for DOT, and we saw the costs for the tests, which were typically $65, they were run elsewhere, drop down into the single digits with rapid testing that we could do in the office. And I think we ended up spending like $5 or $8 for Walmart and others. So I think moving forward, just like drug testing for employers, where the cost came down dramatically for those workplace safety things, same thing with workplace safety for COVID testing. The entrepreneurs out there are rapidly figuring out how to do screening tests that you can do right there, point of service, and they're going to be single-digit dollars. So just to be reassuring when it happens. Right now, we're paying for COVID tests.
Thank you very much, Bill. Is Lucy Hodder still on? And if so, does she have any further questions?
She is.
Senator Mark Butler, could I just make a comment on vaccines for 1 minute?
Sure thing. Sorry, Mark.
I think the good news is Lucy asked us one question that's taken 25 minutes. So it's there's a lot of parts to it here, but I just want to make a quick point. I think that we covered the testing piece pretty thoroughly, but when we think about vaccination, we think about safety, we think about distribution, and put it in perspective, about 40% of America gets a flu shot right now. So when we start thinking about wide-scale vaccination for COVID, we aren't even at a point in America where 50% of our population feels it's valuable to get a flu shot. So there's even if an effective and safe vaccine becomes available, I think we're still going to have a tremendous hurdle to get people to say, I think it's safe, I think it's going to work. I believe in it. There's all kinds of theories you hear around COVID right now. Okay. I wouldn't say I'm in a lot of different geographies in the country, and I would say the way we look at COVID in the Northeast is not necessarily the way it may be viewed in other parts of the country. We're very serious about it. We did early shutdown. We're very, I think, strict in observing protocol, but that's going to be a tremendous hurdle to get over. To truly create safe work environments and safe community environments once we actually have an effective vaccine, from my view.
Thank you very much, Mark. Appreciate that. Lucy, are you still on?
Can you hear me? I'm still on.
Yes.
But I think I don't want to be the only one talking or asking. I think this commission meeting, if you are a commission, you are a commission, is a really helpful, makes it very helpful for the public to be able to ask and answer questions, especially during this very critical time. And it's a great idea, and we hope it happens regularly. And thank you for all of your input and time. And thanks to the department for hosting this.
Thank you very much, Lucy. Is there anyone else from the public who would like to provide input or ask questions?
And again, you can raise your hand in Zoom, or if you're on the phone, you can press *9. Doesn't look like it's Senator.
All right, thank you, Alan. The next issue on the agenda is our commission report due November 1. We don't have enough folks on here to approve of a report, but Tyler has graciously offered to put together and circulate a draft. And I think what my suggestion would be is I'll work with, Tyler and I will work together. We'll get a draft out and take a look at it, and then we'll go from there. I mean, I think the substantive action items that we've taken, as you may recall, we're voting to approve of and recommend moving forward with the 1332 waiver design consistent with the legislation and the budget. And obviously we've had other meetings and we've just, given some informal go ahead in terms of market evaluation ideas. So, so I think that's going to be, I don't think it's going to be a super, lengthy report, and I certainly appreciate all of Tyler's work on the report and everything else and helping set up this meeting. Really appreciate it, Tyler. And so we'll get that circulated soon, relatively soon, and we can take, just formal votes via email just to approve it. We don't have to reconvene the whole, if everybody's okay with that. And that's consistent with commission practices and other commissions that we've done. So that's that. Any questions about that?
Senator Feltz, I actually do have a very rough draft, and
yep.
I'm happy to just share my screen to the extent people can see what's included now. And if there are any comments about something we're missing or otherwise, then we can deal with that even right now before we circulated it. And
sure thing.
Okay, so basically it just has the same type of format that I think most people have seen. And like I said, this is the first draft, so there might be a lot of edits, but the charge of the commission is there. It's right out of the statute. It's fairly lengthy, but people will remember that this commission, part of the reason it was set up was because of the pathway to association coverage. That doesn't mean that anything else we're focusing on is not just as important, but the charge is there out of statute. There's a process and procedures. We've met 4 times, and that's just listed here with the presenters. Then there's background on the whole association health plan efforts, the DOL rule, and the later court ruling, and just some background on what we've seen in New Hampshire with membership changes, number of people in subsidized coverage, and then commission activities, which included the presentation on the waiver application, the mechanism, the idea, the support by the commission for that, which you just mentioned. And then finally, just a real brief set of recommendations, which don't recommend any new legislation, but do recommend that the commission continue to monitor changes in the markets, including getting updates on what's happening with the waiver mechanism and our markets in general.
Thank you very much, Tyler, for putting this together and putting this up there. Does anybody have any thoughts, feedback, or input on that draft report? All right, well, a more final draft will be circulated. in the next few days or so, and then we'll get it, whatever input that there might be there, and we'll get it finalized and done. So I've got a couple other next steps and things to think about. One is just as a matter of process, the legislative members, two of which, myself and Representative Ed Butler, will no longer be on this commission. Representative Hunt, Williams, and Senator French, depending on the outcome of the election, I assume that Representative Hunt will be back with us, and he is a solid re-election effort, and I don't even know if he's still on the call. I'm trying to have some fun with him.
I'm here.
There you go. So out of deference to the next legislature, obviously there would be a new chair. There's going to have to be a new chair, but we don't know what the next legislature is going to look like. So why don't we wait until after the election and then figure out what's going on, figure out who's going to be on this commission. And then obviously you all will need to select another chair.
And my memory was this was chosen by the commissioner himself made the choices.
I don't have the legislation in front of me in terms of the chair.
You actually I don't know about the chair. I don't even remember how that got happened, but I assume we elected you. But Tyler, do you remember? I thought it was Roger who created and invited us onto this board.
Yeah, no, this one, remember, this is a relatively new commission, and it's one that the meeting was set up by the first name person, but that the commission elected a chair. So that's all it says. And it's in the legislation that way.
Okay. So in terms of our position, like we're the chairmen of the insurance committee. I wasn't sure why we're here rather than someone from Health and Human Services or something.
Oh, well, yeah, Representative Hunt, I don't have it in front of me, but I think you were appointed, I suspect, and again, I don't have it in front of me, by Representative Hinch as being the
Republican representative.
Yeah. Yep.
Okay.
So let's wait until after the election, and then we'll have a meeting, and things will get passed off, and it will be seamless, I suspect. And a seamless transition of power on the commission to study the status of health coverage markets for individuals and small employers. Beyond that, obviously, there are some things coming down the pike that I think is worthy of the commission obviously taking a look at and potentially preparing for. And as you may know, the ACA has an oral argument on November 10th. If the ACA is determined to be unconstitutional, obviously this commission's role and what it does is going to be even that much more important. So just as a flag for everybody, and I'm sure everybody on the Zoom chat knows that oral argument's coming up on November 10th. And so I would ask commission members right now to start thinking about and preparing for, if it is overturned, what you would need to do on this commission to help inform a robust conversation about where we need to go here in New Hampshire. So that's all I have. Is there anything else that anyone wants to bring up before we conclude and adjourn the meeting?
We just have to, as a reminder, I have to go through the roll for adjournment. So we need a motion to adjourn, and we got to go through that whole thing for the right to know.
So moved.
Second, any discussion? Hearing none. Alan, would you be so kind to call the roll?
No problem. And this is the roll based on who is actually present right now. So Senator Dan Feltus.
Yes.
Representative John Hunt,
Yes.
Tyler Brennan,
Yes.
Dr. William Brewster,
Yes.
Nancy Pat. I think I got a nod there. George Chait,
Yes.
Lisa Girton,
Yes.
and Kelly Bryant.
Yes.
There you go, Senator.
Well, thank you very much. Thanks, everybody. Commissioner Tyler, everybody for being on. Really appreciate it. Representative Hunt, great to see you. It looks like you're on the lake right now. It's a beautiful view. Enjoy it. And we'll see
Lisa
everybody.
knows where I am. I'm down by the beach, but different
There you
beach.
go.
This is my New Hampshire beach.
In
but-
God's country.
That's
There
right.
you go.
It's all right. Don't forget to vote. Have a good day.
Got it. Go vote. Go vote.
Thanks.